Cataract surgeon essentially, but Kip has given me the topic and I feel honored. Residency in ophthalmology actually prepares a trainee to be safe and practitioner in the specialty, the study of medicine, medical colleges by the AIOS and ARC.
Admin, can you mute Dr. Vinita Gupta, please? Admin, can you mute Dr. Vinita Gupta, or she can do it herself? Thanks. Sorry, sir. Please go ahead.
It's perfectly all right. So it provided huge gaps in the ophthalmic infrastructure and the lack of the subspecialty training services. Well, I would say, you know, a wet lab is not as elaborate as it would be for cataract. You can use a 4X loop, a spotlight, and a phone. The mobile phones can be used for digital recording. Even for cataract, I think when you are doing a wet lab, you might as well do it with the loop and a spotlight. It can actually be coaxial. I have seen those days when Professor Daljit Singh used to operate, and he actually used to dissociate both of them, and he used to use with a magnifier, operate with a magnifier, and splendid surgeon he was. So essentially, this documentation is required, as I was hearing the previous speaker speak, to evaluate the performance of the trainee. And we have to create this facility to record and study the wet lab thing, and it must be a structured curriculum. And of course, you know, we should also have digital recording, and you know, you can edit it and compile it properly, and to actually activate the PGs, because this gap, I don't find why these gaps are there, because when we were PGs, you know, we were given, even in 82, we were given an indirect ophthalmoscope, the one that was available in the institution. And anybody finding a hole had the right, we had the xenon photocoagulator at that time to barrage that hole. So, I mean, another thing is, which Dr. Basat practices in our hospital, is reverse keratoplasty. Like from the recipient's cornea is grafted to the donor button. So the trainee can actually perform those things. So this discrepancy between the mean and the median is pretty high, and we've seen it's been shown many times. But you know, these kind of things are very elementary to begin with: lid abscess drainage, collagen, tarsorrhaphy, visceration, cornea. You can actually, scraping a corneal ulcer is an art. You know, you must learn how to do it. Corneal foreign bodies, corneal tear repairs are the next stage. Hyphema, going inside the eye is slow, but yes, one should. And obviously, as I said, reverse keratoplasty and amniotic membrane suturing. And we must be able to treat emergencies also. So these are the DCR and DCTs. You assist a few and you can go. Once, you know, with the pediatric ophthalmologist, you can be familiar with the probing procedures and you can do it. I mean, at any point, the key is that the moment you feel that you are not comfortable enough, you should stop. Cause no harm in your learning process. Collagen, definitely before giving the infiltration anesthesia, mark the collagen, because after the infiltration, it becomes very difficult to. And tarsorrhaphies, I think these are initial procedures. Depilations, lid lacerations are a wonderful thing, but it's a very tricky thing. But you must read a lot and learn how to do, because that's the time in the hospital when actually the senior consultants are not around. So in bigger teaching formats, these are the places where you can do a lot of clinical work and surgical work. So definitely do that. Small excisions are very smart, and definitely follow up on the biopsy reports. And of course, evisceration, step by step, you can go ahead under supervision. And these are the initial cases with which we start. Even strabismus surgery under supervision. One thing good about the, other than cataract or glaucoma surgery, is that generally there are a vast group of patients where you can do no harm. So essentially, I would insist the trainers to focus on these areas, and because in the list we saw that it's very few, but we should give the trainees ample opportunities in this area. And of course, these procedures, as I told you before, the corneal suturing is an art, so one needs to learn it properly. For a rupture like the one at the top here, one needs to check out for scleral perforations. So, and of course, these are tricky purse string sutures, but you can try them because it can always be reversed. Whatever you do here, it can be reversed, but mind you, these are very astigmatic, very vision areas, so one must be very careful. And of course, the peritomies and the corneal foreign body removals, pterygium surgery, corneal grafts, hyphema removals, and of course, cycloda and intravitreal injections, especially in the pseudophakic eye, can definitely be done. So in all, we should give a lot of part of the training, and I hope the PGs get sufficient learning which helps them later in their life. Thank you very much.
Thank you so much, sir. Thank you so much. Quickly, Dr. Mohan Rajan, sir, would you like to give any advice, tips, your views on this concept?
It's a beautiful talk by Debasish, as usual, because basically you're all ophthalmologists, basically, and just because you're an ophthalmologist, it doesn't mean that you cannot differentiate cardiovascular sounds. You can't forget your SN-2 stethoscope. Similar to that, you are an ophthalmologist, basically, you're a general ophthalmologist. During my residency, I'm sure Debasish is also done. I've done everything, starting from lid laceration, lid repair, tarsography, blepharoplasty, everything. I've done everything up to the orbit we have done. And of course, subsequently, I became a VR surgeon and cataract surgeon. That's a different issue altogether. But basically, you have the opportunity as a postgraduate to open up, to learn everything in the 3 years. And that is, I think, the important take-home message I want to give. And things like chalazion, corneal tear suturing, and especially when you are in emergency in the night duty, you can do that. You can do lid lacerations. All these things, you can do it very nicely without any problem at all. That mental block and the self-doubt should be overcome by the postgraduates. If once they overcome that, then it's very easy for them to do everything. It's not difficult at all. Of course, for the specialized surgeries like the keratoplasty and other things, retinal, the vitrectomies and other things, you need some, definitely some fellowship and other things. But definitely you can get away with most of the common things what Debasish are beautifully mentioned in his presentation.
Thank you, sir.